Dr. Spiess is currently the Associate Chair for Anesthesiology at the University of Florida School of Medicine in Gainesville, Florida. He has previously held positions at Virginia Commonwealth University, the University of Washington, and Rush University. His wide expertise in the areas of blood research and patient blood management have included over 200 articles and more than 40 book chapters. Dr. Spiess is also an accomplished speaker. Of special note to our audience, Dr. Spiess was the first to author research studies regarding using thromboelastography for heart surgery. Today, Dr. Spiess will be speaking on patient blood management and how it fits in the context of COVID-19. Please welcome Dr. Spiess.
Good morning, all. I am trying to share my screen, and it's just starting to come up here. So
Okay.
I'm not sure if you can see things. Hang on one second. Let me see if that is that coming up. Something's coming up.
Yep.
Okay.
And then I think you just need to go to the view.
There we go.
There you go.
All right.
That's great.
Oh, the panic of not having your computer do what it wants to do, or it doing what it wants to do, not doing what I want it to do. Thanks. It's great to be back with so many good friends. It's really tough to follow after Jonathan Waters. He's such a erudite, great statesman for patient blood management, and he and I overlap on so many different ways. Excuse me. But I'm thrilled to be here today to talk to you about a fascinating subject, and it's something that's not being put into the news much, and that has to do with blood transfusion and COVID-19. Excuse me. Let me have a sip of coffee. Hang on. There's so much to do with blood that once you start digging into it, it's frankly scary. I will touch on some things that I think I might be a bit outspoken on. And if there's ever been a time for us to really practice and dig into patient blood management, it's now. And I'll show you the reasons why I believe that. So we'll start off with a bit of an outline about pandemics, history and context. All of us are living through today's present day pandemic. We should always remember that the biggest deaths, the largest number of deaths in mankind's history have been from pandemics. Disease is what culls the population. Wars and stuff are far less of a problem than our pandemics. And if you think this is the last one we're going to have, I got some thoughts for you. It's going to come around again and again and again, and whether they come more frequently or not, we can argue about. We'll talk a little bit about some underlying science. Some of the science for COVID. There's a lot you hear about on the news media and stuff, but there's so much going on behind the scene, and frankly, there's an explosion in medical knowledge that's occurring that's been, I think, unseen in the history of mankind, and it's fascinating, and in many ways, it's great to be on that forefront. There's an explosion in Ecmo usage. We can talk about that. That probably affects your specialty a fair amount. And some of it's good and some of it's bad. The reliance on Ecmo for COVID has, as I said, many ethical overlays, but what if all the Ecmo machines in your hospital are tied up with COVID patients and they're tied up for 6 weeks at a time or longer? What's the right thing to do? Is COVID hematogenously, boy, that's hard this early in the morning, hematogenously spread? Is it in the blood supply? I'm going to put it to you right now, it is. The blood bankers in the United States, at least, don't want to know that. They don't want you to know that. They don't want to talk about it. But if you go to some of the literature, it's out there. And then we can talk about pandemic models, what happens as pandemics take over the blood supply. And we can talk about immunosuppression with transfusion, COVID implications, on and on it goes. There are so many implications. So I'll digress off on a slight tangent with a few of my thoughts on the COVID virus. It's a clear and present danger. It's a moving target. These data, this slide I first made out in March, but look at the explosion, and these data are already old. And today's data are old compared to yesterday. And we get pretty fatigued, each of us, with news media fatigue of COVID, as I guess as Trump said, COVID, COVID, COVID. It's all we hear about. But it's really huge. And where you are depends a lot on your experience. COVID wards in New Jersey being put up as standalone hospitals. I don't know if we have any standalone field hospital situations going on in the United States right now. But with the explosion that's presently happening, it wouldn't surprise me if it does. And human frustration is rampant. It's not just our country; it's rampant worldwide. And people are doing strange things because of the frustration. And I will say that pandemics in the past have destabilized nations. They destabilize governments. They destabilize economies. It's not just you and I on the medical care front, but there's every part of society goes through it. So you might think viruses were an evolutionary step towards bacteria, et cetera. But if you really dig into it, they're a throwback. In other words, probably viruses could never exist on Earth until we had eukaryotic organisms with multiple cells. In other words, a virus is merely a piece of nucleic acid that's surrounded by protein and perhaps a lipid coat. It has to have a cell, and it really has to have multiple cells to be able to survive, replicate, and exist. So a virus has to have evolved sometime after bacteria and potentially after multicellular organisms came to exist on Earth. So it's not really a pre-bacterial little nucleic acid piece of material, because as I said, it can't replicate without having some other cell to function as a host. So it as a pest or as a vermin or as a it had to evolve sometime later on. Now, our little fella in one artist's rendering can look rather beautiful. It can also look like a water mine in some war zone. And we spent lots and lots of times in the lay press about these spike proteins that hang off, and we'll talk about those spike proteins in a bit. And that's how the virus actually attaches onto our pneumocytes and potentially other cell sites as it goes through the respiratory tree. But we have ACE receptors throughout our body, not just in our lungs, not just in our pulmonary circulation. So that may be a fairly ubiquitous way that it binds to cells. So a few factoids about infectious diseases. As I said, this has been the largest culling of the herd ever, is through infectious diseases. The first one we know about is in about 5000 BC in China, where an epidemic probably occurred because there are mass burials all over in China from that period. And it goes on and on and on. Obviously, we know a fair amount about the Middle Ages and plagues, but the first bubonic plague may have killed as many as 5 million people in the Roman Empire. And if you think about it, the Roman Empire at that time was only about 10 or 11 million people worldwide. So 5 million was, 50% of the population died. I attend on Thursdays a very unique think tank group of people working on the front end of COVID worldwide. And this think tank group last week discussed two of the unintended side effects. Maybe that's not the right word for it, but two of the unique observations that are occurring right now. Bubonic plague is back. pneumonic plague is back, and it's back as a side effect of COVID. It's complex, but plague and tuberculosis are exploding worldwide, and it may be because of some of the things having to do with COVID. We could dive into that if you wanted to. And here's a bunch of the rest of the plagues that have gone all the way up until 2009, 2014, 16. You know, swine flu in 2009 and 10 was, we thought it would explode the way COVID did. It didn't, but still worldwide, 574,000 people worldwide died of H1N1 flu. And I'm going to show you some data where BARDA and the NIH and the FDA have used it to model what would happen had H1N1 flu exploded in the United States. Now, it's interesting they modeled that, but they never did anything with their model. And so they knew about it. They knew what was about to happen, but people just wrote academic papers and never did anything with it. And of course, Ebola's out there. Ebola is rearing its head again in the last 6 weeks or so in Western Africa. And then there's Zika, West Nile, MERS, SARS, and now COVID-19. SARS, MERS, and COVID-19 are all coronaviruses, all have this unique lipid coat that has the spikes and use the same methodology for entrance into cells. So we ought to learn some things out of that. But we also ought to learn some things out of our medical public behavior in terms of these most recent epidemics. And Zika and West Nile particularly for blood banking should be telling for us. We should have learned from them, but I'm not so sure we have. We live in a global world. I don't know how many of you have stepped on a plane recently. I just did because I'm up in Chicago right now seeing an elderly mother. But you know, none of us have traveled much in the last year or so, year and a half. I certainly used to be, a big international traveler. I'm not doing that, but still, even today with limited travel, we're still moving our viruses around the world, whether we like it or not. And you can say, well, where's the virus? Where is the virus? What is the real world picture? And you can say, here's the hot spots for the epidemic. But I'm going to tell you, this is a picture that's wrong. It's upside down. It's incomplete because we don't get information out of Africa, South America, Oceania, Southern Asia. We don't get reliable information and reports daily on, hey, how many people reported to hospital? What's the chance of doing a PCR in Zimbabwe to find out whether somebody has or does not have the COVID virus? Doesn't happen. Not going to happen. No, there's only three PCR machines in Africa. So what kind of information are we going to get? We don't really know what's going on. So the underlying science, it's really complex about the COVID virus. Here's one of the fascinating things is, these glycoprotein binding sites that attach to the ACE surface are very important. That's been widely studied, but how it gets into the cell is something really important. That's actually something I'm working on. And that's a therapy that I'll show you at the end with using inhaled adenosine. We can stop that from happening. We can clog up the pore wherein the virus enters the cell by giving inhaled adenosine and stopping the process. I'll also tell you that at the end of the lecture, I'm going to talk about how we use inhaled adenosine to potentially prevent the iatrogenesis of us making the lung disease worse. So oxygen, you guys care about oxygen. That's what perfusion's all about, is getting the oxygen to the patient and maintaining the circulation. So oxygen is really important, but too much oxygen kills you. You know, I've given lectures before called oxygen, the vital toxin, and too much oxygen kills you. Just the right amount is good. Too little oxygen, you got hypoxia. But what do we do in COVID? We give patients oxygen because they're so systemically hypoxic. But when we enhance the oxygen delivery into their lungs, we short circuit the release of adenosine, which is the natural release of cells to hypoxia. And in doing so, by giving that oxygen, we make the inflammation worse. We may actually be creating the T cell cytokine explosion because of our own therapeutic desire and utilization of high inspired oxygen concentrations. And once the virus goes into the cell, it comes out of its little lipid membrane, and then it goes to work. It goes to work remanufacturing itself, and it takes over the cell's entire energy production. It steals ATP, and ATP, what's ATP? Adenosine triphosphate. And 40% of the COVID virus genome is adenosine. So we'll get more into that at the end. And adenosine, as I said, has a lot to do with this cytokine storm. I'm working on that. I'll show you some of the cool data of what we're trying to do. So COVID, you don't usually die from the virus. You don't die from the virus. You die from the runaway inflammation triggered by the virus. And you die from the runaway inflammation triggered by the virus, potentially with the overlay of the medical care team trying to take care of you by intubation, by giving more and more oxygen. And that feeds back into the T cell hyperinflation and this cytokine storm. You know, we've been hearing about clotting, and I mean, we can dive into whether or not this Janssen pharmaceutical clot situation is real. We should be worried about it or not. And that's not the same situation as what's going on with the actual COVID patients. But the incidence of thromboembolism with COVID is tremendous. And given long enough period of time in the hospital with you and I caring for patients, every person will become hypercoagulable and a real risk for thrombosis. So the complications go on and on. ARDS, acute respiratory failure, kidney injury, septic shock, DIC. You know, I was just, Jonathan Waters was just talking about DIC. We'll talk about DIC a little bit. DIC is poorly understood by most of us, poorly characterized, and a continuum of disease heading into disaster. But neurologic systems, strokes, a chronic neuritis goes on, and myocarditis. I happen to have been one of the physicians that cared for the basketball player who had the cardiac arrest on in the NCAA game. Severe myocarditis from COVID. Had COVID 2 weeks before, severe myocarditis. How do you get myocarditis? How do you get severe, long-standing neurologic defects if the virus is only in the lungs? The virus has to get to these other organs. So, you know, for somebody who says, you know, the virus doesn't go by the blood, well, wait a minute. Does it or doesn't it? It's in the breast milk. There are many reports of, you know, lactating women who've just gone through childbirth, and the fetus comes out and is born with COVID. There are case reports now about whether those children do fine or not. They appear to be. They appear to not get the pneumonia that some of us old farts like me are likely to get. But they have been born with COVID virus. And it's in the breast milk, and it's in the myocardium, And why? So how does it get there if it doesn't go through the bloodstream? It isn't just magic, so it's got to get there somehow. And what fascinates me is that if you go to the literature from the Far East, particularly the Chinese and the Koreans and now the Japanese are testing their blood supply. And they're finding COVID virus. They're finding COVID virus in their blood supply. Here are 4 patients out of 1,000. So they tested 1,000 donors. And these were asymptomatic donors in Wuhan. Okay, so Wuhan, we're all focused on Wuhan as being the epicenter, but these people were asymptomatic. Asymptomatic blood donors, 4 out of 1,000 tested positive for the messenger RNA virus in the bloodstream. And when I've talked to American blood bankers, they say, yeah, it's just a messenger RNA. We don't know if the virus is actually capable of replicating. And yeah, it's just the RNA. It's not the full virus. How do you know that? If your test is only to find this PCR sequence, how do you know whether it replicates or not? You want to take that chance? Well, in Korea, they actually have a case where it was positive in the blood, came from the donor, and actually caused symptoms and led to COVID infection in a patient who got the blood transfusion. Now, if you gave blood in the United States and it had COVID in it, how would you know? You'd have no idea. And if your patient came down with COVID, was in the hospital, let's say had heart surgery, you gave blood on the bypass machine, 5 days later they came down with COVID, what would you blame it on? Everything else in the hospital, some other exposure, some respiratory exposure, an exposure from either somebody who was visiting or from some of the healthcare workers. Nobody in the United States would blame or look for it in the blood supply. So we have not the foggiest idea either what we're doing or whether it's even possible. Yeah, it's possible. I mean, I just showed you it's possible. It's reported, it's out there. But the US blood banking system refuses to look for it. They refuse to look for it. So there's Europeans. The Europeans have said, well, we're actually worried about it, but we wish not to spend the money to do a PCR on every donor bit of blood that's drawn. And so we're just going to have you self-report. And if you've either had COVID or symptoms, 21 days until you can donate blood. Okay, that's one approach. But, self-discriminating or self-keeping you from donating may not be all that effective. And there so far are no U.S. recommendations that I'm aware of, other than they ask you when you donate blood, have you had a fever, have you been sick? Obviously, they take your temperatures. But the U.S. statement says you cannot get COVID from a blood transfusion because this is a respiratory virus. Because this is a respiratory virus, you cannot transmit it through the blood. But wait a minute. We just said that you can get myocarditis and you can get neurologic defects and you can get it into the breast milk. So it goes through the bloodstream once you have the virus. And the classic one that I've been told to my face is this didn't happen with SARS, therefore it can't happen with COVID-19. Okay, was there ever a SARS patient who donated blood? No. Was there ever asymptomatic SARS? No, we got 40% of COVID-19 patients are asymptomatic carriers that nobody knows about. And China has already shown that you can donate that in the blood. So shouldn't we at least study it and know something about it? So there were only 35,000 confirmed SARS cases in the United States. And as I said, nobody was asymptomatic and nobody donated blood. That's not a very good argument for me that we shouldn't try to find out whether or not that actually works. So what did the US do in February, March, April, when things were exploding, even into June and July, when things were exploding in 2020 and we were all closing everything down and circling the wagons around our hospitals. And the blood supply in the United States crashed. I'm going to show you that in a couple of minutes. And who did we get to donate blood? Healthcare workers. Well, yeah, we donate blood a lot of the time anyways, because we're great altruistic people. But who was the highest risk group in the United States for coming down with COVID? Us. And who was the highest risk for being potentially asymptomatic carriers? Us. So, is this the brightest thing we could have done? Who's to know? But if you don't test and all you do is say a self-deferral for temperature and stuff, could there have been some contamination? So we really need to learn from history. And the history, unfortunately, with blood banking is not really spectacular in terms of fighting viruses. Every lecture I've ever been to by a blood banker says, one of the biggest risks is viruses. Okay, good. We know that, AIDS, hepatitis. But they always say, well, the biggest risk is the next emerging virus that we don't know about. Okay, now we've got an emerging virus we've just found out about, but now we're unwilling to go and look for it. They don't have a stellar history in terms of AIDS. For a number of years with the AIDS crisis, the blood banks worldwide told us that it couldn't be transmitted by blood transfusion. Of course, right now we know that's absolutely not true. And when it was traced in France to the utilization of factor VIII concentrates, it led to 20-some blood bankers in France being actually jailed for 20-year terms because of their failure to be willing to admit to, detect, and follow it. So let's go, and the same thing goes on for Zika and West Nile virus. So between January and June of 2020, there was a 70 to 85% drop in blood supply in the United States. Imagine what happens to your hospital if all of a sudden you are in a crisis where there's no blood. And I would imagine most of us during that time had notifications from our blood banks that said, hey, we're really short on blood today. Hey, we're really in trouble. There were 5,000 in March alone in the United States, 5,000 blood donation drives were suddenly canceled, eliminated, just plain didn't happen. Now, I can tell you that in the United States today, on any given day, we use between 30 to 40,000 units of blood. We have a 3-day supply. So that means the total available supply in the United States today, on Friday, the 16th, is about 150,000 units at best. That's the entire United States supply of blood in the United States. And if we lose donations like that, the well dries up very quickly. But here's the thing, that essentially all elective surgeries in the United States were canceled for a number of months, 3 to 4 months, and demand for blood dropped 40 to 60%, supply dropped 85%, but demand dropped 60%. But it was predicted in 2018 by the FDA that this would happen when a pandemic occurred. It was actually predicted. They did the study, and in doing the study and predicting it and putting it out there, and it's in the academic literature, I'll show it to you in a moment, nobody did anything about that. Nobody did any advanced planning, either in the blood banking community or in Homeland Security or in emergency management. And I, at the time, as it was happening, as I was reading these papers and was so astounded, I spoke to a couple of congressmen about it and said, what are we doing about this? And they were incensed, but looking at all your wonderful faces, it will not astound any one of you to know that things don't move fast in Washington, D.C. And frankly, nothing got done then, and nothing got done now. And so I was at one point asked to write an editorial about some things having to do with blood substitutes. I wrote the editorial, and called it When Blood Is Not an Option. Medicine on the brink. We cannot allow this to happen. But it was rejected because it was quote unquote too strong. It was too much in the face of everybody saying, hey, wait a minute, we're sitting on the edge of a precipice and we need to do something. That article was focused on the need for a blood substitute, an oxygen therapeutic. And you all know that I've spent a big part of my career working on that. And maybe it sounds self-serving that this is now a call for why we need a blood substitute. But get this. When the pandemic hit, we came this close to not having any blood available in the United States. What happens when we don't have any blood available in the United States? Can you do heart surgery? Can we take care of trauma? What happens to the lady who has that postpartum bleed? We're back in Africa. We're back in sub-Saharan Africa where you got nothing and you live or die. And that's where we were, and we have been sitting on the edge. And we're one next explosion away from that happening at every given time. And so these are the studies that I bring up and I talk about. So the United States lives by a FedEx, UPS, DHL, just-in-time blood delivery. And I mean that literally and figuratively. In other words, we harvest from the supply, it gets put into a warehouse, that's your blood bank, comes out of there, and the movement through that system as a system is great, as long as the system is never broken, as long as there's never a glitch in the system. And on 9/11, there was a glitch in the system. The planes hit the towers and they hit the Pentagon and the nation shut down. We didn't use any blood to take care of any casualties because everybody was dead. But all of a sudden, and for the next 5 days, FedEx didn't fly. And there was a national blood shortage because there are 11 centers that do AIDS and hepatitis testing in the United States. There's hundreds of blood centers, 750 some blood centers that collect blood, but they're all dependent upon the 11 centers to process that blood, and it has to be sent by FedEx, UPS, DHL to get to those places to be tested. And if you can't fly there, you can't get it, and all of that blood can't be tested and can't be used. So blood supply in the United States is based on a regional pattern of supporting blood centers that help and support each other and move blood around. And you can see that, the relative percentage of blood in these 4 different regions of the United States. So there were simulations. This was actually a simulation, interregional blood supply simulation to evaluate blood availability and support planning for emergency preparedness. And the idea is that if there's an event that happens, say in the West, that there can be backfeeding by FedEx, et cetera, UPS from the Midwest or the South. We can flood in blood supply from elsewhere in the United States if we need to flood into the center where the problems have existed. But what happens if it's a nationwide event? What happens if it's a nationwide event and it all happens suddenly? Or what happens if it happens slowly, indolently? So in this quote unquote silicon research, in other words, that's a computer modeled research, the FDA and the NIH took this model and said, what happens to the US blood supply and the movement of blood around if we have a pandemic? And let's model that pandemic on H1N1 flu that we just went through. And let's make certain assumptions. And from those certain assumptions, let's see what tumbles out to the fragility of the US blood supply. And, remember after 2008, when the financial crisis hit, they gave these tests to banks, the New York banks, to see how fragile U.S. banking system was. This is the exact same test. How fragile is the U.S. blood banking system? So they did it with two tests. One is a pandemic test, and the other one is one that would scare the crap out of any one of us. The detonation of a thermonuclear device, 20 kiloton thermonuclear device, goes off in a US city. What happens to that? Which is worse? Which is worse, the pandemic or the explosion of a nuclear device in a major US city? I'm going to tell you, the pandemic is worse. So we're living through the worst of predicted events. And, right now the blood supply is okay because of a number of, frankly, just lucky things that have occurred. Not because of any great planning, but because of some lucky things that have occurred. So in their model, and I encourage anybody who really thinks this is cool, is read this paper. In their model, they modeled a pandemic lasting 13 to 20 weeks. That's pretty funny, isn't it, right now? Wouldn't we have loved the COVID pandemic to only be 13 to 20 weeks? We can't see the end in sight yet. We're celebrating that, we're all getting vaccinated, but are we really at the end of the pandemic? So they saw a 5% drop per week of blood supply in the United States, and they modeled about what that would do over these number of weeks, and then a 7% increase as they came out of the pandemic. And they modeled it, and what did they find? That over the duration of the pandemic, the 13 to 20 weeks, there would be a deficit of 550,000 units of blood in the United States. 550,000 units of blood in the United States. Now, remember, in the United States right now, we use about 13 to 15 million units of blood annually. And so one of the perhaps things that they didn't model into this was that surgery was going to cut and demand was going to cut. And because nobody's traveling on the roadways, trauma drops like 80%. And that's all of some of the things that we actually saw in reality. So they modeled it and came up with a 500,000 drop. Now, here's what happens when a thermonuclear event happens in a major US city and they blow off a bomb, is that, lots of people die immediately. They get incinerated. They're now just atoms scattered to the wind. But the further out you are from the center of the disaster, the more severely injured you are, the closer in you are. And some people have burns, and all of us know that burns require large amounts of blood for care. And then there's people who will have secondary effects of radiation who need to go into the hospital, and miserable, horrible things. But the demand for blood out of that is in the several 100,000 units of blood, but it's isolated. And it could be backfilled from the rest of the country. And so the explosion of a nuclear device, say in Los Angeles or New York or something, is far less destructive than a constant pandemic. And so it's just fascinating to read this and say, okay, we knew about that. Why didn't somebody take that signal and say, we could be in a in a national shortage situation here, and they didn't. They just published a paper. Nobody did anything structurally to the blood banking system. And so there were interregional flow and dips and replenishments, and all these models came about. And so what we have seen is that we, at least at my hospital and in the state of Florida, we dipped into the red zones where we had, 10 or 20 units of red cells. In the University of Florida hospital, the hospital of 1,400 and some beds, we had 20 units of red cells on some given days. We were at 0 platelets many, many days. And there was all kinds of demand. And, who went and answered the demand was you and I, the healthcare workers, the workers who had the highest risk. And ostriches stuck their necks in the sand and said, well, we really don't want to know whether that can carry virus or not. Israel has a 15 to 30 day supply of blood stockpiled for mass casualties for their entire population. Who lives with war all the time? Israel. Britain has a 10 to 15 day supply stockpiled for mass casualties. They went through the Northern Ireland bombing situation, and they've been used to terrorist bombings through that, and they've built up their supply. U.S. supply is very tenuous. We sit on a 3-day supply. And there still today is no path forward for a blood substitute through the FDA. And in the last year, I've talked to multiple people in the FDA by phone, as well as congressmen, and they simply can't wrap their head around the fact that if we run out of blood, we've got nothing. And they just can't wrap their head around it. Going back, as I said, we don't have a very good record on what we do with viruses. West Nile virus, I remember West Nile virus in 2003 and 2004. It was raging. It was raging in the Midwest, largely along the Mississippi, the mosquito belt. Mosquito belt was where West Nile was. Now, West Nile virus is clearly contracted and is spread by blood spread. So the mosquito bites you, feeds on the blood, bites the next person, injects a little blood, bingo, you got the West Nile virus. But blood bankers refuse to look for West Nile virus, said it can't get into the blood supply. It's not a problem. We won't have it as a problem. And they refused to look for it. Eventually they did look for it. Eventually they made a PCR test, just like they do for AIDS and hepatitis. And what actually happened was that the national infectivity of reported cases of West Nile virus, as soon as the blood bank started to eliminate it from the blood bank, dropped by 60% the following year. So how much were the mosquitoes doing it and how much were we spreading it? Nobody knows. And nobody's still willing to even understand and look for it. So West Nile should be instructive to us that if you look for it, you might find it. And if you eliminate it, you might take care of a problem. So it ought to be instructive for us. But so using less blood, to me, today, is extremely important for all of the reasons. One, we still have shortages of supply. It's certainly not a place to turn on the tap. Well, let me go back to West Nile for 1 second. In 2004, the FDA sent a notice to every physician in the United States, came as a letter. Was it CDC? I think it was CDC, not FDA. I remember getting the letter in my mailbox, and it said, we need to inform you that the United States blood supply is infected with West Nile virus. And in certain places in the United States, the chance of contracting West Nile virus is 1 in 400 units. Do not transfuse your patients unless it's medically life and death necessary. You know what happened to blood utilization in the United States during that period of time? Nothing. The physicians did not change the transfusion behavior, even with the CDC saying, here we are in a life and death crisis and physicians still transfused. Here we are in a similar situation and patient blood management was never more needed. This is a call article that just came out, Harry Shander and a whole bunch of us signed on board to it to say, wake up, America, wake up and do patient blood management at your medical center. There are still only 8 medical centers in the entire United States who are patient blood management certified to be certified centers by the Joint Commission. Many of us do bits and pieces of it, but to be a fully certified center, it needs a lot more. And the World Health Organization said that this is vitally important. Not only that, in the face of COVID, but overall, the World Health Organization has demanded that hospitals worldwide get involved with patient blood management. So let me go on with a few more things about treatment for COVID. The world has responded with vaccines, thank goodness. I breathe easier. I walk around easier. I actually get together with some friends right now without a mask, as long as we're all vaccinated. Isn't that a wonderful thing? There's hope for us in our future. And some treatments are working, maybe partially. The death rate has dropped, but not dramatically. I mean, when we first started out, the death rate was about 2.5 to 3% overall in good hospitals in major Western countries. The death rate right now is about 0.8% to 1.2%. So have we dramatically fixed everything with the treatments we've got? Remdesivir, convalescent plasma we'll talk about. But we fundamentally, globally need a way to treat this, and we don't have it yet. There's a group of us studying the fact that in the United States, 94.6% of all proposed randomized trials for treatments for COVID are languishing and not being supported for trials. The ones that are going forward are being supported by major pharmaceutical houses, big money, big pharmacy, and many interesting ones that make all the scientific basis are just not going forward at all. So let's talk about convalescent plasma. I'm not going to touch on hydroxychloroquine. That's not a place I wish to go today. But let's talk about convalescent plasma. That has something to do with blood. It has something to do with blood banking. And it got a big splash that, and it actually got FDA emergency approval for utilization of convalescent plasma. Well, it's not a new idea. This was around in 2015 and before, that if you have a runaway viral infection, perhaps you could take the plasma from those patients who've survived the runaway infection, harvest them if they have high titers for antibodies, and use that plasma into somebody who is now infected. Okay, that makes a great story, but think about it. You're going to take 1 unit of plasma, 250 cc's, 220 cc's, and put it into Ty Walker and expect Ty Walker to suddenly get better because he got, because he got 5% or 4% of his total circulating blood volume and he got a few extra antibodies. And this comes out of the H1N1 flu and SARS, and it was trialed in SARS in a few limited studies. And they were very limited, they were biased, they were profoundly biased, and they weren't well controlled, but they did show a decrease in mortality. But if you're going to use convalescent plasma in those situations, it had to be early in the disease. So when COVID came around, everybody wanted convalescent plasma whenever and however and how badly ill you were. And I'll put it to you that if you're on a ventilator or you're going on to Ecmo, the time for convalescent plasma has long since passed. And nobody knows about dosing, redosing, how much to give. And let me tell you, this well isn't very deep. In other words, the amount of convalescent plasma that we can harvest from the American public is not very much, and it's not a very useful therapy. So it's now, and this is work that was just recently published in the New England Journal, says that if it's going to be effective at all, it has to be utilized in first cases early on when the virus is just beginning to infect the patient. And that makes the sense that if you're going to target with an antibody to kill the virus, it needs to be upfront early on when the virus is just coming around, not later in the disease. So, think about the ethics, think about who gets this. It's a scarce resource and it's costly. It's thousands of dollars as a scarce resource to get it from your blood bank. And so, this again, early use, 250 cc of high titer plasma. And I don't really know how high a titer is a high titer to make it effective or not, but it's got to be early in the disease, not later in the disease. And it's not something that we can do for everybody. What have we got? How many millions of cases have we got in this country? How many hundreds of thousands of people are dead And how much convalescent plasma has been utilized? Not more than tens of thousands of units. So it's not a utilizable technique. And what about ECMO? Okay, ECMO, again, a blood situation, a situation for you guys, something that affects your lives. I don't know how many of you here on today's call have put patients on ECMO with COVID, but I suspect you have. I have been involved with 4 lung transplants where the patient came into the operating room on ECMO, being kept alive by ECMO as a bridge to transplantation. We're the center that has done the largest number of post-COVID lung transplants in the world. And ECMO is our bridge to lung transplantation. And some people are on ECMO 6 to 8 weeks awaiting a lung transplant. And every one of the people I've done, of the 4 I've done, has been younger than 42 years old. So, these are people who were previously healthy, and ECMO kept them alive. But it's a very expensive treatment. It's very complex, and it's got tons of issues. Gee, how difficult is it to run ECMO when a patient's becoming ever more hypercoagulable? Does that make your life more difficult? Okay, so, and ECMO, there are only about 400 or some centers around the entire world that even have the capability of ECMO, let alone large numbers of ECMO. So ECMO is just not really a viable alternative for this disease whatsoever. And again, if you put somebody onto ECMO and it's going to be 6 to 8 weeks until they get a lung transplant, that's one less ECMO machine for somebody else who might need it for post-heart surgery or elsewhere. And, in South Asia, that's all of India, Pakistan, Bangladesh, Thailand, and Africa, there are 18 ECMO machines. What's the population there? So why even really talk about ECMO? So World Health Organization is trying to put some guidelines about when you use it and when you don't, but you damn well ought to have an ethical exit strategy. If you're going to go into a war, how are you going to get out of the war? You need to figure out what you're going to do to get people off of ECMO. Recovery from ECMO is possible, but it's extremely highly unlikely. So unless you tell the family and use it as a bridge to transplantation, I personally think you're fooling everybody, and you're doing health service a very large misconduct. And if you're going to cannulate, I think you need to cannulate venous to arterial, because the lungs can't support the blood flow. You can't do veno and expect that your cardiac output is going to be maintained normal. So you really do have to do that. And the hypercoagulability is poorly understood. And using daily heparin makes it get worse and worse. So a couple words about COVID hypercoagulability, and then I'll take some questions. It's yet to be fully characterized. Don't forget that coagulation is the first part of inflammation, and when inflammation runs wild, it dumps gasoline on the fire of coagulation, and trying to put a fire out by smothering it in gasoline generally doesn't work very well. So it gets worse. And cellular debris, huge amounts of tissue factor, platelets upregulated, cytokines, ischemia, vasculature, adenosine flux, all have effects upon the hypercoagulability. And the hypercoagulability may be partially iatrogenic. Why is that? Because we're giving everybody heparin. And if we give everybody heparin, either low molecular weight or intravenous heparin, to try to prevent, we're actually creating HIT antibodies. And there is now work underway that shows that HIT antibodies are skyrocketing. And one of the questions is, do the antibodies being created to COVID have an overlay with HIT antibodies to begin with? Or is this all iatrogenesis because we're using so much heparin in these patients? It's a situation I don't have the answer to, but the role of the anticoagulation in the COVID-19 world pandemic is fascinating, and it may be that once again, we're not helping things, we're actually making them worse. And most of us here know who Ted Warkentin is, and obviously he gets on his hit bandwagon, and he's written a wonderful article about it, and I encourage you to read it, to dissect into, which is it, chicken or egg, which is it, the doctor or the patient that's causing the problem. And yeah, we need to do something, because otherwise these patients appear they're going to get hypercoagulable anyways. But us trying to treat it may get it worse. And over time, if we leave people long enough, they will all become hypercoagulable. And DIC is hypercoagulability run wild over time. In other words, if you produce enough thrombin, over time, you will eventually consume all of your products and you'll go into a DIC situation. So it's just a matter of time. The longer you stay in the ICU, the longer you're on Ecmo, the longer you're getting heparin, the longer you're ventilated, the more likely you are to die of one of these disastrous side effects. And given long enough, every one of us will thrombose if we're had COVID and we go into the hospital. There's viscoelastic testing, TEGs, and now Quantras, and the hypercoagulability is profound. I know you guys are pretty good little TEG readers, and if you look down on the left side, look at that outer, the real TEG versus the normal, which is in a dotted line. That's one of the most hypercoagulable TEGs you could ever see, and you're going to see that with COVID patients in the ICUs, profoundly hypercoagulable. The FDA actually made a call for it, that everybody who's got COVID ought to be followed by TEG and viscoelastic testing. Now, here's the thing. Only 30% of hospitals in the United States do any viscoelastic testing for anything. And now the Quantra is being used. I don't know if you know what the Quantra is, but it's a new ultrasonic test to be able to look at coagulation as point of care. There's a bunch of papers coming out on it. It's FDA approved. And in Europe, it's being used in France. This is a case from France, and I'll put it to you on that dashboard on the left. Green is good. Things way over to the right are hypercoagulable. Things way over to the left are hypocoagulable. At least 4 of the readings here on this patient having to do PCS is platelet contribution to clot strength. FCS is fibrinogen concentration to clot strength. Clotting time is up there on above, which is like the R time of a TEG. This patient is severely hypercoagulable, as is this one in the Netherlands. So we're starting to see that this test can be utilized. Now the question comes in, if you see that, then what do you do? Still, nobody really knows what to do. I think I'm going to go through this 1 or 2 slides and say to you, we at UF, under my leadership, are trying to trial a human trial. We're trying to get a human trial of giving adenosine. Adenosine is the natural cell signaler that is released when hypoxia occurs in your cells. So HIF-1 alpha is a protein ubiquitous to every one of our cells. The 2019 Nobel Prize in Medicine was given to Greg Semenza and 2 other men for their discovery of HIF-1 alpha, and the understanding that this iron-based protein senses oxygen at our cells, and when it senses that a cell is hypoxic, it releases adenosine. Adenosine, of course, vasodilates the local vasculature, increases blood flow, but adenosine also is a profound downregulator of T cells and a profound downregulator of platelets. And so what happens when we get somebody who has got COVID? They've got COVID pneumonia. They come to our emergency room, we give them oxygen. And the minute we give them oxygen, we short circuit the body's natural response, which is to turn out adenosine. And the more oxygen we give them, the more we turn off the adenosine. And so the more we turn off the adenosine, the more the killer T cells, which are invading the pneumonia, are upregulated to keep invading. And you have you have collateral damage that these these T cells that are invading now C cells that don't have adenosine, and they kill them too. And those are our surviving pneumocytes are getting killed. So we're trying a human trial of inhaled adenosine over 5 to 7 days. We've cured 2 people with it. The Italians are seeing a 95% success rate in cure for severe COVID. And I think I'm going to stop there because I can give you a whole nother lecture just on our utilization of adenosine, but it's potentially a future trial for us that we might be able to use to treat our patients. The Italians had 13 or 14 patients who survived with adenosine treatment who would have otherwise died. We've had 2 that have done that. And I think I will just say beyond COVID-19, we need therapies for acute respiratory distress syndrome. Utilization of adenosine, we think in the future will be great for all ARDS, potentially post-heart surgery, post-transfusion, post-sepsis, post-trauma. And so we're looking at it for a long-term utilization. And I'd be glad to take any questions. I'm probably just about out of my time, but I'd be glad to take any questions if you want.
Dr. Spiess, I know you aren't necessarily watching the chat, but people are really enjoying your talk for sure. In the chat, they have lots of questions.
Okay, so read me some questions because I'm not watching it.
So the common theme that kind of keeps coming up in a lot of the questions is, why are we not testing the blood supply? Or why do you think the FDA is not interested in looking into this?
So we didn't do it for AIDS. We didn't do it for West Nile virus. We didn't do it for Zika. Why didn't we do it for any of those things? You have to ask the question of, if you're going to put Standard Oil in charge of environmental protection, what kind of environmental protection are you going to get? If you're going to ask the blood bankers about, policing their own industry, and so who does Congress call if they want to know something about the blood supply? They call the American Red Cross. Who responds and says, what's important to the American Red Cross? It's and who sits on the FDA in the oversight groups? They're all blood bankers. So I don't really know. I guess I'm being kind of damning that I think we're just repeating history over and over again, and we're not really doing what we need to do, which is embracing patient blood management and looking with, real in-depth view. I am sure that the amount of COVID-19 that's getting into our blood supply may be fairly small, but we ought to know about it. And it would probably cost a lot of money to do PCRs until we get a really, cheap test.
Well, thank you so much. I know that that was really informative, and I appreciate you coming and speaking with us today.